We have identified a number of opportunities that we think exist in long-term service and supports. We'll talk about those. We will continue to review those. So, in one sense, the process of payment reform is coming to agreement over time as to the opportunities for improvement, because the distance in policy planning between agreeing on the opportunity for improvement, often a matter of data, policy understanding, programmatic understanding, clinical judgment, the distance between understanding that opportunities exist to improve and actually addressing those opportunities with changes in the way we do things, that distance is very narrow. And so in the other areas of payment improvement, we don't agree in 1 month on the opportunities for improvement, and 7 months later, without any change in any of that, agree to the change, to a new way of doing things. The opportunity to improvement is something we learn about really as we develop the improvement opportunity itself. They become one and the same. The identification of a problem that can be solved and the solution become one and the same. And we're still in that process.
We had a stakeholder meeting last week, and we finally got to the table and got to express some concerns that we've had before. It was our idea that those ideas would be expressed and we would work out those problems before we came to one of these meetings. But now it seems that we're still going to have these public meetings, and goals and things are stated and conclusions are drawn. And so then we have to go back and we're chasing those errors or those issues that we bring up in these meetings, but we're already having new meetings, so we're always behind the curve, we the stakeholders, and we don't understand where our input really is being felt in this process. And it seems like today we're seeing new statements and new conclusions being drawn, but still last week we had a great meeting where we got to talk about issues that we had in the past 2 meetings. So it's almost like we're going somewhere, but we're working out the issues and the problems after we've already gotten there. And I think we'd like you to kind of explain to us how we're not getting ahead of ourselves.
Jim, I have learned not to explain a negative. I learned that in marriage. So I'm not sure I know exactly how to answer your question, other than to say that yes, we will continue to meet in this setting, in the large group setting. We'll continue to agree to meet in smaller groups on an interim basis. And we will continue to make and follow through with the commitments. I know that we have listened to concerns about some of the data that you'll see today, and if those concerns are borne out in that process in the next work group, you'll see the updated result. We are reluctant, though, to pause the process for any significant period of time. We will never make a decision based on what we know to be an incorrect assumption. So what you're seeing here is fluid, and in the spirit of transparency, we're having this meeting so that everyone knows where we are. And I'm sure as we go through this, there'll be an opportunity to identify those points of data that or conclusions that are still an issue.
Okay, so I guess we're going to have these public meetings as they are without having any screening of the data or the statements that are coming out in the public hearings, but we're going to have the work group meetings behind the stakeholder meetings to work on things that have already been said in these meetings.
It's an open and transparent process with both small and large group meetings. It is not deliberative in the sense that a legislature might have a committee process, and so the work groups are not formally a committee that has to pass off on data before it would come here. we know that we run the risk when we share data publicly that will be criticized if it's inaccurate. In this case, we're explicitly saying there's an opportunity for review and continued improvement, and we have not come to any policy conclusion yet. In the spirit of transparency, I think that hopefully you and other stakeholders would like to know where we think we may be headed, even if that's not where we end up. So again, the context is at the last group we shared perspectives on the current state of long-term services. You'll see those summarized in the next page. We have spent the past few weeks pulling together initial perspectives on changes to the current long-term service and support model. We feel this is a strong initial step towards capturing the opportunities that we have seen so far. But as I said, confirming those opportunities is a long-term process, and we may not ever all agree on the opportunities, but we will not likely coalesce around the specific opportunities and data points until just about the time we agree on the recommended solution. Those two do go together, and they're iterative. Our objectives today are to go over several key design elements so that you know where we think we're heading, gather your feedback on them, what we have missed, what risks are posed by the design, are there options that may help us reach our goal, and always to understand your perspectives. We have work group questions that are posted. We have opportunities for email questions, and Jim, as you've mentioned, there certainly will be smaller work group meetings, usually at a stakeholder's request, for example, in the meantime. And we are trying to make progress on level setting with the data, which, for those of you who aren't involved in the other components of payment improvement, we're going through exactly the same process. So no secret to anybody who's aware of it. We've been at the public work group process with developmental disabilities for a lot longer and are still working very diligently to level set on sort of describing the current state of the world in the area of developmental disabilities, early childhood therapy, etc. Here's what we shared last time. As Jim said, not everyone agrees that this is a description of the current state of the world, and this description may change over time as the work group progresses. As the red lettering at the top says, this is a preliminary working draft subject to change. Essentially, it will be that until the legislature reviews it in the regulatory process and CMS, of course. The first opportunity that we hypothesize is getting people to the right setting of care. Description of the current state of the world. It currently costs more per year to care for clients in a nursing facility. Not that surprising. There's room and board included. It's a different setting. A significant percentage of nursing facility residents and an unknown but likely positive percentage of community-based service recipients display lower levels of need using the available data that we have. So we have focused on the data we have, which is MDS data from the nursing facility. We do not have that same comparable data for community-based services yet. We will by the time the process is over. Second, matching level of care to need. Nursing reimbursement now is not designed to do that. There's no surprise that it doesn't, because that's not how we pay. And that makes it difficult for some providers to care for the highest needs clients. And that's not just true in nursing facilities. That would be true across the healthcare setting, the healthcare spectrum. Currently, facilities with lower needs populations have per diems that are equal to those with higher needs populations. Third, and this is a goal and an opportunity across all of our activities in payment improvement, and that is to align incentives with outcomes, align our payment with outcomes. We've already begun to do that in the area of medical care, and the physicians or hospitals working with us, and we have 5 episodes of medical care already in place. We and our private partners have engaged already, and so we're already in the performance period for some of these reforms in the area of medical care, and this effort is to do the same for long-term services and supports, that's both nursing homes and community-based care. Arkansas nursing facility per diems lagged behind states a little over a decade ago, both because of the nursing home assessment quality fee and associated increase in payments, and because of continued increases not completely funded by the assessment. That has reversed, and we're at the upper end. We may not be at the top end of the scale. One of the criticisms of our data last time is that we didn't include every state in the comparison to nursing home rates in Arkansas. It's a fair criticism, and we'll be adding other states, and we may not be exactly at the top. We're at the upper end. The current 5-star quality rating only allows a predetermined number of high performers. This makes it very difficult, and we've heard criticism both from the industry and from our own analysis of the 5-star quality rating system. My dissertation was actually in the comparison of rankings to quantitative measures. And so I spent thousands of hours thinking and working on this issue, and this is not necessarily the way you want to pay if it's a ranking. Occupancy is 73% compared to a national average of 83%. Not all of that likely is because of the way we pay. Some of it probably is. The demographics and spread of a population, et cetera, are going to affect that. There's no doubt. Coordinating care. Long-term service and support clients are commonly dual eligible, and about half of their total costs come for non-long-term service and support services. This is an acknowledgement that this reform effort is not all about institutional or LTSS payment reform. It is also about the comprehensive care of the individual. And today, no single party assists the client in coordinating their care across long-term services and non-long-term service. How about we just say medical care? I don't even know how to complete that sentence. Today, we'd like to get your feedback on a few of these points. 4 potential elements of our future long-term service and support payment model, which is designed to capture these opportunities. In terms of getting people to the right setting of care, and these 4 goals, here are the principles that we're going to discuss. Clients must make setting of care choices with full knowledge of their eligibility and assessed level of need. So there's a sequence that we're hypothesizing is important. We know what somebody needs before they get it. Second, clients should receive services and funding that's appropriate to their needs. Third, the payment mechanism should reward both efficiency and quality. And let me say, quality is always a component of the payment improvements that we're making, but it is not always the case that we explicitly pay for quality. It's not always easy or possible to do that. We see a real opportunity in long-term services support to do that, and so that's our intent. And fourth, performance should be measured in such a way that each provider has the opportunity to succeed. That's a principle across payment improvement. And by the way, in some cases, in other areas of payment improvement, like the patient-centered medical home, we know that we will have to make an investment in those providers in order for them to succeed. If we're asking them to really adopt a different business model, And if we want to succeed, then that means providers have to succeed. This is not adversarial. It does involve change. It involves facilitated change and appropriate payment. And there will be analogs to that dynamic and I hope, in long-term services supports.